I want to talk about really evaluating your own heart health. And it's kind of a step-by-step process. And I'm going to give you a little background as to why this is so important to me. I'm going to start with an experience that I had, and I've nicknamed this. It's not very a nickname. I don't mean to make light of it. It's called the death of the museum curator. In 2012, I was operating in urgent care in southeastern Idaho. And this beautiful lady that was in her really early 60s, I think she was 61 or 62, she came in and she had this complaint. She says, Randy, I've got this heartburn and it doesn't go away. I've had it before. I ate some bad food the other day and gal, I've been taking over-the-counter reflux medicine. I just can't get it to go away. And I think I need a prescription. So I said, well, would you like to do some testing? And she says, no, I'm not yet Medicare eligible, and I have a really tight pocketbook. So I'm pretty guarded about how much healthcare costs. I'm going to pay for your visit, and I want you to give me what your best thought is about how I can minimize this acid reflux. So no additional testing, just kind of give me some medicine or something. So I put her on the typical purple pill, the acid reflux medicine, and I actually gave her some samples. Back then, these drugs were newer. I had some samples in the sample closet that the drug rep left for me. So I said, hey, why don't I give these to you? Let's have you make some dietary interventions and we'll see how you do. She said, great. She came back to the office not long after that and said, that just hasn't been working. I think it was about a week later. She said, that just hasn't been working. And gosh, it's worse when I lay down at night. It's always worse after I eat. I'm just not working well. Can you give me something else? And so we have something in the medical office called a GI cocktail. And this cocktail has a little bit of Maalox and belladonna and some viscous lidocaine. Really, we're just trying to numb pain. I gave that to her. Then she says, yes, that really helped. Thank you so much. I think we'll be good. And then the following Monday, the county coroner called my office and said that she was found dead after she didn't show up for work. The family went to her house. She found her half on the toilet, half on the bathroom floor. And so he called and said, apparently you were the last person that really took care of her. So what do you think happened? And I sat down there and I was thinking, oh my gosh, did I miss a heart attack? And I told the coroner, she came in twice for acid reflux and this kind of burning sensation in her chest. I suspect she had a heart attack. And he says, well, we're going to do an autopsy. And of course, the autopsy, in fact, revealed a massive atherosclerotic lesions throughout her heart. She had a massive heart attack and she passed away at home. I was the one that signed her death certificate. And I vowed I would never let that happen again. I was so distraught. This was really one of the first times since graduating that I felt like I was directly responsible for someone's demise, that I could have done more. And it was hard on me for a long time. And so I spent a lot of time reflecting on what did I miss and what could I have done better in that case. And there was a part of me that said, well, she really wouldn't let you do any testing. So, Randy, it's not your fault because you probably could have figured it out if you could have just run your regular battery of tests. And then there was a part of me that says, hey, it doesn't matter. I need to be good enough that I could pick out issues and understand risk, really understand who's at risk. So the fact that she was a 62-year-old menopausal woman should have stood out to me. The next thing that should have stood out to me was, hey, heartburn that lasts all day long, even when you're not eating and at work, that should have stood out to me. The fact that it was unresponsive to medicine should have really clued me in. But I was enough of a rookie that I missed that. And so how do I practice different now? What's different about my practice based on that? Number one is I don't blow off signs of imminent risk ever. I will compel, I will say, hey, listen, you're not leaving my office. I'm going to do this test. Hey, then let's not bill you for it. Something. I've got to prevail and do some additional testing. The next thing is I've gotten so much better at stratifying risk. And when I mean that, stratifying risk means identifying what's really risky and what's a talking point, okay? Age, gathering medical history, looking at true plausibility of a problem, and then differentiating between primary and secondary prevention. I'm going to talk about that in my discussion today. Use of really easy in-house screenings or things that people can do at home. I can tell you a really simple stress test that you can do if you think you have a cardiovascular risk problem. You can do it at home on your stairs. It's pretty simple to do. The next one is everyone talks about cholesterol lowering medication. Really, that's kind of what maybe prompted you to come today. What is he going to talk about? Cholesterol medicine and a statin? Do I need it? What are other interventions? And really, I want to offer you this multitude, this toolbox of symptoms, or excuse me, this toolbox of solutions that really help you as a client take a sense of control and get a pulse on what your actual cardiovascular health is, no pun intended. And I want to empower you with as many home-based interventions as are possible. And you'll see as we go through this, really today I only have time to introduce them. But over the coming months, I'm happy to dig deeper with them. The first thing is you have to really understand what cardiovascular disease is. And I don't think we make that obvious in medicine. Cardiovascular disease can be a disease of the heart muscle, right? That can be a cardiomyopathy. Your heart's dilated or it's a little bit floppy. It's enlarged. It can be kind of like a congestive heart failure issue. It can be a disease of the blood vessels. So we talk about cardiovascular disease as the blood vessels that feed the heart, the blood and oxygen that it needs to serve as a pump. Those have circulation issues or there's plaque built up in them. It can be a disease of the rhythm of the heart. Most of you are familiar with atrial fib or bradycardia. That's a low heart rate, or tachycardia is an elevated heart rate, right? So it can be a rhythm issue. It can be an issue of inflammation. Most of you may not have realized that cardiovascular disease is actually listed as an inflammatory condition. It's not just an atherosclerosis or plaque issue, it's an inflammatory disorder. So if you have liver issues or dental issues or autoimmunity, you're certainly going to have a much bigger risk factor for heart disease. So I've listed some pictures there, right? The actual structure of the heart, and then there's the rhythm of the heart, and then there's these inflammatory markers that start goobering up. They start boogering up the pathways so that the heart just doesn't function very well. And that's what's tricky because all of those are considered as cardiovascular disease. So guess what? If you have a rhythm problem, a statin isn't going to do very much for you. If you have terrible inflammatory pathways, statin may do a little bit for you, but you better dig a little bit deeper. Okay, so that's my point, is really kind of identify, we have to really look at what is driving cardiovascular disease. Now, I went to the CDC and I've pulled this out to show you as early as 2023, the number one cause of death adjusted for age, right? We're looking at age-related deaths because just making that adjustment for age, heart disease is by far the biggest. So when we talk about really trying to understand cardiovascular disease, it's pretty important because it's the number one thing that takes people. All right. So the way that I've tried to build this presentation today is helping you to better understand risk. What is my risk and what is driving your risk? Are you considered high risk or low risk? And then why are you considered high risk and low risk? I think that's important. And in risk, when we read a medical journal or a study, there's a lot of talk about evidence-based medicine. A hazard ratio is how we quantify that risk. And we're saying, what's the risk of an event in two populations that might be the same or have just a couple of similarities or differences? So let me give you a graph of that. Let's say that over time, the bottom half of your screen right here where my mouse is, the bottom half represents aging, the aging process. And then the top part is your survival rate. So are you going to 100% survival rate, or your survival rate goes down as we age? So when we look at a hazard ratio, we're comparing a treatment against no treatment. I think that's important to know. When we measure the effectiveness of a cholesterol lowering medicine like a statin, we're measuring it against not doing anything. It's the statin versus placebo. So you can already, I hope you sense within the tone of my voice, that's kind of an unfair study anyway, but at least it tells us if a statin medicine is better than doing nothing at all. Okay? That's really what we're talking about here. And when we talk about hazard ratios, this is kind of the medical definition. If when we read a study, if a hazard ratio is 1 or equal, then the treatment is no different than the placebo. They're exactly the same. So a hazard ratio of less than 1 means that the rates are lower in the treatment group, right? And if it's greater than 1, the rates are higher in a treatment group. So this is important because we're going to talk about percentage of risk, right? And let me walk into that real quick. I want to give you a little bit more background just personally as I've walked through this. On the left-hand side of your screen, I'm showing you a picture of my cute little family. Now that picture is old because this young man right here giving my wife a snuggle turns 26 years old or 27 years old this year. And this little booger at the bottom of your screen, Lexi, is now 15 years old, and my baby's not even in that picture. Okay. But my wife says, why are you showing that picture? Do you want one more accurate? And I said, no. And it's because this young man right here was born on the day I was defending my thesis for my graduate degree. And during that time, I learned these guidelines for cardiovascular disease. And the goal for cardiovascular disease was lower your LDL. That was what I learned. That's what I was taught in graduate school. I came out of school and my focus was just lower LDL. And you'll see, these are the guidelines from the year that I graduated. High risk, moderate, or low risk. And what are these numbers here? These are odds ratios. These are hazard ratios. Remember, and I told you that anything greater than 1 signifies that's different from placebo. So we knew that if you could lower your LDL, it lowered your risk of cardiovascular disease. Well, let me dig into that a little bit deeper. These guidelines came from the National Cholesterol Education Program. It's largely funded by the American College of Cardiology. And the guidelines that came out were called ATP-3 guidelines. That was the adult treatment plan or the adult treatment program, which was the best science-based approach, published originally in 1997 in the journal Circulation as part of the American Heart Association, and it was focused on LDL, baby. That's what it was. All right. Well, there was also a focus in lowering your risk factors. So I posted this, but I'm going to talk a little bit more about risk factors globally. But you can see if you don't get good sleep or if you don't have a very healthy diet. Now look at this, is interesting. It's a DASH diet or a Mediterranean diet. DASH diet's low salt. If you're a little sedentary and don't get physical activity, if your blood sugar's elevated, if you're overweight or your cholesterol's up, blood pressure's high, if you're a smoker, these are all predictors of cardiovascular disease. But the focus of the ATP-3 guideline was LDL cholesterol. So right down here at this bottom part, this was my focus coming out of school. I've now become much more broad in trying to minimize the risk by getting rid of your potential risk factors, or at least helping you to identify them. Risk factors, according to the American College of Cardiology or the American Heart Association, are divided into modifiable and non-modifiable risk factors. Let me talk about the non-modifiable over here on the right-hand side of your screen. You can't modify your age. You can't modify your sex, even though in our current society, there's a lot of people who think you can modify your gender or your sex, right? I don't want to wax political, but you are what the good Lord gave you. So you can't change that sex. Your family history, you can't pick your parents, right? You just have them. So it's important to know if the men in your family, like your father, died before the age of 55, that's a much higher risk factor. Or if the women in your family died of heart disease before the age of 65, that's a higher risk factor. African Americans or individuals with black skin they have a higher rate of heart disease. That's statistical. We know that. But you can't modify that. You can't modify your ethnicity and sex and so forth. So let's shift our focus over here to these modifiable risk factors on the left-hand side of your screen. We can do something about your blood pressure. Now, if you run around with high blood pressure, you're 1.5 or 2 times higher risk of heart disease, period. We know that. You can modify that. Your cholesterol depends on your risk group. Are you 70 years old or 30 years old? Which cholesterol is high and how high is it? It's kind of linear. So the higher your LDL gets, the more risk. It's somewhere between 1.3 and 3.0 times higher, but there's some dependency in there. If you're a smoker, it's off the charts. The highest risk assessment, second to it's higher than anything else. Diabetes is actually fast approaching that 2 to 4 times. If you're diabetic and your blood sugar is always elevated, you have a much higher risk of heart disease. So that might clue you in. Well, should you take cholesterol medicines? Are you a smoking diabetic who's overweight? Uh-oh, you're in trouble, right? Lifestyle. How about if you're sedentary? Do you get up and move? Answer me this. I want to ask you this question. If I get up at 6 o'clock in the morning and exercise for 45 minutes, and then I sit on my chair and work a 12-hour day, do I have an active lifestyle or a sedentary lifestyle? You see my point? I think that we all say, well, I exercise. We go to an exercise class 3 times a week. And so we say, well, we have an active lifestyle. I don't know that that counts, especially when I sit on a computer all day long. And an unhealthy diet, I didn't even put a risk factor there because no one knows what it is. Number one, you have to define unhealthy diet. Is that a keto diet? I don't think so, but some people think keto is unhealthy. Is if I have a bowl of ice cream every day, am I eating unhealthy? What if I like some corn chips once in a while? So unhealthy diet is really tricky, and we can talk a little bit more about that as we go. I'm happy to answer some questions about that, okay? This slide is so busy, but I do a lot of teaching and training of doctors and nurse practitioners. So this is what I use when I train them. Up here where my mouse is on the upper left-hand side of your screen, I put 2004 because that's when I finished graduate school. But these guidelines came out in 1997 and LDL was the focus. Let's really focus on cholesterol. And they gave goals right down here. If you are a high risk, then the goal was to push your LDL less than 100. If you're a low risk, then we would allow some tolerability there. You could keep your LDL, 150 and it's not that big a deal. Over here in the middle part of my graph, in 2013, the American Heart Association updated their treatment protocols. And they said, hey, look, we're going to focus on risk beyond just LDL levels. We want to know the highest risk people are people who've actually had a heart attack in the past. Heart attack or a stroke are the highest risk. We're going to be focused on them. We're going to shift our focus to statin intensity. You might think, what the heck is statin intensity? There's about 10 or 12 different statins on the market. You want to understand which one is considered a high intensity or a low intensity statin, because the higher your risk, the more intense that statin we want it to be. Still a focus on diet and exercise and weight management. But in 2013, it was still a very statin focus guideline. Well, the guidelines got updated in 2018. You can see I've done a fair amount of work. Now, this is my interpretation. So if there's nuance here that I'm not going into, this is just Randy Vaudry going through each of the guidelines and understanding them. In 2018, they reaffirmed the position from 2013, and they said, hey, we reaffirm statins are important. But we're not necessarily checking statins to decide if we should lower cholesterol. Remember, the earlier guideline says if you are high risk, we're going to lower it to a certain level. In 2018, they said, we don't even need to check your cholesterol. You should just get a statin if you have enough risk, right? If you're male, high blood pressure, history of smoking, overweight, diabetic, you just get a statin, and I don't really care what your cholesterol level is. But we use an LDL check to evaluate how effective is your treatment. What's your response to that cholesterol lowering medicine? They went back in and added these, they called them risk enhancers, which means that your risk goes up if you have other issues like kidney disease or other inflammatory conditions like autoimmunity. And this was really the first time they came in and said, if you have a client that doesn't want a statin because they've heard bad things about them, then we recommend you get a coronary artery calcium score right here where my mouse is, so that you can help quantify that risk, and then consider a little bit more diagnostic cardiology appointment. Interesting, isn't it? This is how I have run my practice for years and years. I have shifted away from only being focused on statin to really understanding what is driving those risk factors. Well, before I shift away from statins, I want to show you this. This chart shows you high intensity, moderate intensity, and low intensity statins. Sometimes it's a reference to what statin we use and what dosing are we going to use. The higher dosing obviously is more intense. But the conversation gets more difficult. Even if you look on the bottom right-hand side of your screen, we have statins that are lipophilic. That means they like fat. And we have statins that are hydrophilic. They like water. Well, why does it matter? Let's talk at the lipophilic statins. These statins are generally more effective. They cross cell membranes better. They're evenly distributed throughout the tissue. So they're not just in your bloodstream or in your liver. They actually get into the tissue, but they have more muscle-related side effects. If you're going to get leg cramping, it's going to be because you're on one of these statins that are lipophilic or fat-loving. And these statins are more likely to have a drug-to-drug interaction because they're metabolized by the liver. And the liver is also metabolizing other drugs. So if the liver starts getting clogged up with all these medicines that are trying to be metabolized, you're more likely to have a side effect. These statins on the other side are more water soluble. They primarily function in the liver instead of all throughout the body and the tissue, and they generally have fewer side effects. Okay, so that plays a role. It especially plays a role in cognitive issues because the brain is a really high fat organ. And so we might choose to use a statin that is more water soluble and has less side effects. It might actually give less brain fog because it's not so lipophilic, right? So that's a way that we can kind of marry the guidelines of the use of a statin in individuals who are kind of brain foggy, but they have high risk, okay? So let me show you how risk calculators work. If you go online and you go to this site up here called Med Calculator, and you type in Framingham risk score for coronary heart disease, you get a little calculator like this. And it's really fun. All you have to do is plug in your demographics. So I'm 52 years old. You'll see I put in 52 right here. That's my age. And then I said, I'm a guy. So I mark male. I'm not a smoker. I put my total cholesterol level in there. That's an actual number. And my HDL, that's an actual number. And my blood pressure, that's an actual number. Okay. And then they ask me, are you being treated with blood pressure medicines? No. And then you hit calculate and it tells you your results right down here. An average risk is 10% risk of having a heart attack sometime in the next 10 years. And I'm at 5.3. So if this would be considered moderate risk, I would be considered low risk. So that would then factor into what I choose to use a statin. But let me tell you, the weakness of this calculator right here is this calculator looks at 7 variables. But on the right-hand side of your screen, it doesn't ask you, are you an exerciser or are you sedentary? What was your blood sugar and your insulin level? And are you a diabetic or insulin resistant? Because I just told you, diabetes has a risk factor that's almost equivalent to smoking for heart disease. It doesn't ask me my family history, right? And I just told you, if your dad died before the age of 55 of heart disease, or your mom died before the age of 65, that's increased risk to you. It doesn't calculate my hormone levels. Did you know that women have a much lower rate of heart disease when they're having a period? The moment they go through menopause, they have the equivalent risk as men. We used to think heart disease was a disease for men. Nope, it's a disease for men and menopausal women. But this calculator right here doesn't equate my hormone levels. It doesn't ask me anything about my diet. What am I putting in my mouth every day? It didn't ask me my weight. Am I overweight or not? It doesn't ask me, do I have other issues like autoimmune disease, other vascular issues, right? Autoimmune disease or vascular issues like erectile dysfunction. Do I have varicose veins? Have I ever had a stroke? Those things would factor into it. Now that tells me it isn't that I'm at risk for, I actually have a vascular problem. And the calculator doesn't ask that. Do I have a history of blood clots? What's my omega ratio? Do I have an omega 6-3 ratio that's too low? Because I can tell you that factors into this by the research. What's my uric acid level? Or do I have gout? Because that's a predictor of heart disease. Do I have sleep apnea and do I snore like a chainsaw all night long? Well, that's not factored into it. What's my homocysteine level? Homocysteine is a marker of vascular inflammation that tells me the health of your blood vessel. And if homocysteine level is greater than 7, you have more risk than the average person. So we want to drop that homocysteine level. What's your CRP? Well, CRP is a marker of inflammation in your total body. And I told you earlier that heart disease is actually an inflammatory disorder. What's my coronary artery calcium score? In my opinion, every single person over the age of 40 should do coronary artery calcium scores. And it's in all of my roadmaps. I recommend that we do that because it's a predictive risk factor, not just for heart disease, but for cerebral vascular disease. What's my dental health? Maybe you didn't realize that if you have dental abscess or gingivitis or periodontal disease or receding gums, or you have a bunch of silver amalgam fillings that are old and starting to oxidize, or an old root canal, you have more risk of a heart attack. Okay? Now you see the complexity of, if I'm hyper focused on your LDL, and I'd run a Framingham risk for cardiovascular disease, I am going to miss all of these other risk factors that become predictive of cardiovascular disease. And I don't want to miss those. So I go back to the death of our museum curator. Number one, I didn't even know her cholesterol. Number two, I didn't know if she was diabetic. I did know that she was menopausal at the time, but I wasn't astute enough to pick up on it at that time. So in my opinion, when we get hyper focused on, should I be on cholesterol medicine or should I not? Should I be on a statin? Are they good? Are they bad? You're missing the point. That's only one part of the discussion. And when I teach cardiovascular disease, I teach it in modules. I teach risk factors. So I have an entire lecture that's geared towards blood pressure management, blood pressure checks, how to check your blood pressure when you're at home. Do you know that the most effective blood pressure check is when you're at home? When you go to the doctor, it's probably a little bit more elevated because you get white coat syndrome. You're kind of nervous about the doctor putting a needle in your arm and checking your blood, or maybe they're going to tell you to stop drinking alcohol, or they're going to tell you to lose weight and you're hypersensitive about weight loss, so your blood pressure goes up. Every single one of you should have a blood pressure monitor at home, and you should just check it periodically. What's your homocysteine and your D-dimer and your CRP? So these say module 1 through 16 because I teach those modules, right? I'll help people recognize, how does this relate to cardiovascular disease? Now, where on there do you see cholesterol? I intentionally didn't place it because we live in a statin-centric world where that's all we talk about. I'm not afraid of them. I've used them in the past, but generally I think they're a little bit overused, and we underuse these other variables that become predictors of cardiovascular disease. Okay? So, and cardiovascular health is not just about statins. It's not just about LDL. It's a much deeper and more broad health discussion. And think of cardiovascular health like a toolbox. You have lots of tools in your toolbox. So I kind of like this old-fashioned toolbox. I don't know if this is a dentist toolbox. That was kind of a joke, right? But those look like some gnarly tools in there. But this tool right here might be a statin. But all of those other tools in the toolbox are these interventions. These are the things that we can do that really help us identify what is our true risk and what can we do to modify that risk, so we just don't get hyper-focused on what's my cholesterol level and am I willing or not willing to take a medicine to lower it. So with that being said, I want to open it up for discussion.